Hello, welcome to Psych 105, Stress Coping and Anxiety Disorders. So before we move into the anxiety disorders themselves, let's talk about stress. Stress is our response to a situation that disrupts our physical or mental equilibrium. A stressful event can trigger the fight or flight response, causing hormones such as adrenaline and cortisol to surge through the body, as well as norepinephrine, which the textbook also refers to as noradrenaline, a neurotransmitter, to course through our neural system. Some stress can be beneficial at times, producing a boost that provides the drive and energy to help people get through situations like exams or work deadlines. So, stress is not always bad. It can be very, very productive in terms of helping you push yourself when you have a deadline looming. Some people live in traumatic situations, for example, domestic violence or enduring a war or natural disaster, and this causes the body to be in a state of chronic stress. Can stress make you sick? Absolutely. Research shows that stress can contribute to the development of major illnesses such as heart disease, depression, and obesity. Stress also can lead people to self-medicate using alcohol and drugs. An extreme amount of stress can have health consequences and adversely affect the immune, cardiovascular, neuroendocrine, and central nervous systems. Stress also impacts our sleep patterns, often causing insomnia. That's when our brains don't shut off, and focus on unhappy thoughts, problems, and other negative stressors. They become the dominant ideas in our minds. So you'll see here with this chart over here, and this is from 2003, but it's pretty much a consistent amount of anxiety over the last 20-25 years, is people who suffer from anxiety often have a higher rate of acid reflux, allergies, backaches, asthma, fatigue, and migraines. So, you can definitely see how stress can make things worse. So how do we manage stress successfully? Physical activity increases your body's production of feel-good endorphins. These are a type of neurotransmitter in the brain and helps in treating mild forms of depression and anxiety. Also, eating a healthy diet, getting at least 7 hours of sleep is very beneficial. Finding an outlet that takes your mind off of your problems, such as a hobby like playing games, spending time with your children, socializing with friends, and meditation or yoga. Positive affirmations in which you remind yourself that you can handle the day-to-day bumps in the road. And keep in mind that, overall, the more you feel confident in your ability to handle things, the less stressed your body will get, because you have a certain level of self-confidence that helps you get through these tough times. Everyone experiences stress and anxiety at one time or another. The difference between them is that stress is a response to a threat in a situation, whereas anxiety is a reaction to that stress. When faced with chronic or trauma-based stress, a person may develop an anxiety disorder. So when you're looking at the stress curve, you are going to see yourself in that yellow as the optimum amount of stress. When you move into orange, you are overloaded, and when you get into red, you are burned out. Your body has basically broken down, and you cannot respond well to any requests or demands on your time or energy. So, what are anxiety disorders? Anxiety disorders include disorders that share features of excessive disturbance and anxiety and related behavioral disturbances. Fear is the emotional response to real or perceived imminent threat. Anxiety is anticipation of future threat. That's an important distinction to make. These states often overlap, but they also differ, with fear more often associated with surges of autonomic arousal necessary for fight or flight, thoughts of immediate danger and escape behaviors. Anxiety is more often associated with muscle tension and vigilance in preparation for future danger and cautious or avoidant behaviors. So, fear is a response to real or perceived imminent threat. Anxiety is an anticipation of future threat. Again, very, very important distinction. Sometimes the level of fear or anxiety is reduced by pervasive avoidance behaviors. Panic attacks feature prominently within the anxiety disorders as a particular type of fear response. Panic attacks are not limited to anxiety disorders, but rather can be seen in other mental disorders as well. So, the anxiety disorders that we're going to be talking about today include separation anxiety, selective mutism, specific phobias, social anxiety disorder or social phobia, panic disorder or a panic attack, agoraphobia, and generalized anxiety disorder. So we're going to start off with separation anxiety disorder. And this is when an individual displays anxiety and fear atypical for his or her age and development level over separation from people and places to which he or she has a strong attachment. Now, when your 18-month-old baby gets upset when you leave, that's completely normal. But when your 12-year-old freaks out, that's a little bit different. But there's no specified age of onset. Separation anxiety can develop into other disorders, including panic disorder, major depressive disorder, and agoraphobia. It persists in individuals under 18 for at least 4 weeks and adults for 6 months or more. And, as much as it seems odd to think of an adult with separation anxiety disorder, people who are excessively clingy oftentimes are dealing with an anxiety disorder because they're afraid of being abandoned or having this separation anxiety disorder. Then we move on to selective mutism. It is a childhood disorder typified by the inability to speak in certain circumstances. Specifically, it is consistent failure to speak in certain social situations where there is a natural expectation of speaking, such as school. It is often recognized when the child begins school. Selective mutism must be in evidence for more than the time span of 1 month, and it will be determined to have a detrimental impact on school or work. These are not people who are just shy. These are people who literally look like they're going to pass out if you require them to speak in class. Then moving on to specific phobias. This involves having a persistent fear of an object, place, or situation disproportionate to the threat or danger posed by the object of the fear. The person who has the phobia will go to great lengths to avoid the object of the fear and experience great distress if it is encountered. These irrational fears and reactions must result in interference with social and work life. There are 5 subtypes of specific phobia. Animals, and snakes, big one, spiders, big one. Any other kind of animal that some people are afraid of dogs, some people are afraid of cats, some people are afraid of rats and mice. So, natural environment, just touching nature. Ugh. Blood injection injury, so getting a shot, seeing blood, those kind of things. Situational phobias, being afraid of riding an elevator, being afraid of being in tight, enclosed spaces, and other phobias. People can have phobias about just about anything. There are people who have phobias about certain colors, about certain numbers. Social phobia, which involves fear of social situations, is a separate disorder. So moving on to social anxiety disorder or social phobia, it is an anxiety disorder involving discomfort around social interaction and concern about being embarrassed and judged by others. This discomfort will be experienced as fear and anxiety and will be accompanied by autonomic arousal, including diaphoresis, which is sweating to an unusual degree, apnea, which is a suspension of external breathing, and in a sense what you're doing is you're hyperventilating because you're just taking short breaths that they're not deep breaths, they're not getting oxygen to the brain. Tremors, tachycardia, which is an abnormally rapid heart rate, and nausea. It can range in severity to a discomfort which can be circumvented and adapted to a virtually disabling fear with infiltration into multiple areas of life. The prevalence of social anxiety disorder is 7% of the general population, and the onset usually begins in the early teens, and a major risk factor is obesity in teens, because as we all know, teenagers can be a little bit cruel and tease one another incessantly. So it is sometimes a learned behavior that if they do not interact with others, they do not get teased. So they develop this anxiety about interacting with others. Moving on to the panic disorder or panic attack. According to the DSM-5, the most prominent diagnostic criterion for panic disorder is recurrent, unexpected panic attacks. Because the panic attacks are unexpected, they are impossible to predict, and the patient usually feels that they come out of the blue. This surge of fear can occur during a time of existing anxiety, but they can also begin during a calm state, such as while relaxing, sleeping, or while engaging in an enjoyable activity. The DSM-5 describes a panic attack as an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes. And the prevalence of panic disorder is between 2 and 3% of adults and adolescents. And again, when you're looking at something like a panic disorder, you could be sitting there watching TV and all of a sudden you have this overwhelming sense of dread that something terrible is about to happen. And it's not that you're necessarily psychic, it's your body is biologically reacting to anxiety. In addition to these attacks, the patient experiences persistent worry or fear of having another panic attack and often changes behaviors and routines to avoid panic attacks. These symptoms are not related to substance use or other medical or psychiatric conditions. Common features of panic attacks include, again, an accelerated heart rate or pounding heart, trembling, chest pain, sweating, numbness, chills or hot flashes, a choking sensation, nausea, dizziness or lightheadedness, fear of losing control, a feeling of being detached from oneself, kind of a disassociation, and a fear of dying. Within this context, a lot of people end up in the ER afraid that they may be having a stroke or a heart attack. Moving on to agoraphobia. Agoraphobics are most commonly known as the people who have a fear of public places. Agoraphobia is an anxiety disorder involving a persistent fear of crowded environments, often either due to their crowdedness or openness, disproportional to the threat or danger posed to the environment. The disorder typically develops in late adolescence or early childhood and is more common in women. Risk factors include stressful life events, poor health and lower education and income, and biological and genetic factors. Generalized anxiety disorder, or GAD, people with this condition find themselves extremely worried about all sorts of things, even when there may be little or no reason to worry. Patients with GAD may be anxious just trying to get through an average day, always believing that things will go badly. Surveys of the general population suggest that during a person's lifetime, somewhere between 4 to 6% of people will experience generalized anxiety disorder. Women seem to be more susceptible to generalized anxiety disorder than men, occurring approximately twice as frequently in women. The most common age range for the symptoms of GAD to appear is 45 to 59, with a decline in diagnosis after age 60. Symptoms of generalized anxiety disorder must occur for the majority of days over a 6-month time span. Chronic, constant, and often unsubstantiated worry plus 3 of the following symptoms: muscle tension, gastrointestinal discomfort or diarrhea, cha-cha-cha, irritability, fatigue, edginess, restlessness, and sleep difficulties. So how do we manage it? Well, through psychotherapy. There is cognitive psychotherapy, which helps patients to see how automatic thoughts and false beliefs lead to exaggerated emotional responses such as anxiety. And this is where you literally show people where their thinking is going wrong. Then there's behavioral therapy, which involves gradual and desensitizing exposure to anxiety-provoking situations and stimuli, and may include relaxation training to moderate the physiological responses to these. Finally, both types of therapy are effective for anxiety, and a combination generally yields superior results, especially when used in combination with pharmaceuticals. So what we're talking about here is cognitive behavioral therapy, or CBT, which is a very common type of therapy in terms of getting help for these kinds of issues. So the medication one uses for anxiety disorders falls into 4 different kinds of categories. The first one is the selective serotonin reuptake inhibitors, or the SSRIs. These are antidepressants which relieve symptoms by blocking the reabsorption of serotonin, leaving more serotonin available, which improves mood. Basically what it does is it balances one's mood. You need a certain level of serotonin in the same way your body, your endocrine system, needs a certain level of insulin. And if you don't have enough serotonin being produced by the brain, or you don't have enough receptor cells available, your body needs help. So, this SSRI has been proven to be very effective for depression and anxiety. Then we have serotonin norepinephrine reuptake inhibitors, SNRIs, which is also an antidepressant, which increases the levels of the neurotransmitter serotonin and norepinephrine by inhibiting their reabsorption into the brain. And again, this is supposed to balance the mood and balance your fight or flight impulse. Benzodiazepines, which are your anti-anxiety meds like Xanax, Valium, lorazepam. These promote relaxation and reduce muscular tension and other physical symptoms of anxiety. Long-term use may require increased doses to achieve the same effect, which may lead to problems related to tolerance and dependence. And that's one of the big issues with benzodiazepines. And I'll tell you, here's another issue. When people get addicted to benzodiazepines, the withdrawal is so dangerous that people should be hospitalized when they are going through withdrawal, because it could result in their heart or respiration just stopping. Tricyclic antidepressants, which are kind of the older style antidepressant, block the absorption of the neurotransmitters serotonin or norepinephrine, increasing the levels of these 2 neurotransmitters in the brain. These are old school and have a variety of side effects, which you don't tend to see with the SSRIs or SNRIs. These medications are used if there is a concern over addiction to benzodiazepines. Moving on to obsessive compulsive and related disorders, we're going to talk about these 5 disorders: obsessive compulsive disorder, body dysmorphic disorder, hoarding disorders, trichotillomania, which is a hair pulling disorder, and excoriation, which is a skin picking disorder. So we're going to start off with OCD, or obsessive compulsive disorder. And this is one of those things where people say, oh, I'm so OCD, I like to have all my clothes organized by color. Well, that's not really OCD in the sense of a disorder that people suffer with. If you like to be organized, if you like to have things a certain way, that just means that you have a very organized sense of being. OCD is an anxiety disorder marked by the reoccurrence of intrusive or disturbing thoughts, impulses, images, or ideas. These are your obsessions, which are accompanied by repeated attempts to suppress these thoughts through the performance of certain irrational and ritualistic behaviors or mental acts, which are your compulsions. Now, the key here is irrational and ritualistic behaviors. These are not normal behaviors. So organizing your closet by color is not an irrational behavior. That's very rational. That makes sense. However, if instead you are dealing with an anxiety issue and your OCD kicks in, you might in fact take all of your clothes and bleach them white because you can't decide what color to wear. So bleaching everything is irrational and ritualistic. The compulsion may represent a strict rule that the patient must apply rigidly in every situation. For example, always putting the right shoe on first, always wearing blue on Monday, always wearing a certain pair of shoes on a certain day. These are generally very mild compulsions, but they can get really out of hand. The obsessions and compulsions take up large amounts of the patient's time, an hour or longer every day, and usually cause significant emotional stress for the patient and difficulties in his or her relationships with others. And again, if you like things neat and tidy in a certain way, that doesn't mean that you have OCD so much as this is, if you can't do it the way you want to do it, you are ready to freak out in your head. About 2.3% of the population of the United States is diagnosed with the condition, and the typical age of onset is late adolescence to young adulthood, with slightly more women than men being diagnosed with OCD. OCD is not the same as having obsessive compulsive personality disorder. Even though they have similar names, they're very different. The personality disorder is not characterized by the presence of obsessions and compulsions. Rather, it is a lifelong pattern of insistence on control, orderliness, and perfection that begins no later than the early adult years. It is, however, very possible for a person to have both disorders. The most common compulsions in Western countries are washing and cleaning, counting, hoarding, checking, putting objects in a certain order, repeatedly confessing or asking others for assurance, repeated actions, making lists. OCD is presently classified as a form of anxiety disorder, but current studies indicate that it results from a combination of psychological, neurobiological, genetic, and environmental causes. OCD's neurobiological differences. Some researchers have noted that OCD is more common in patients who have suffered head trauma. Recent studies using positron emission tomography scanning indicate that OCD patients have patterns of brain activity that differ from those of people without mental illness or with some other mental illness. Other studies using magnetic resonance imaging found that patients diagnosed with OCD had significantly less white matter in their brains than did normal control subjects. Large epidemiological studies have found a connection between streptococcal infections in childhood and the abrupt onset or worsening of OCD symptoms. And the general nature of OCD seems to run in families rather than the specific symptoms. So mom or dad may have a compulsion to hoard things, and your compulsion is more about washing your hands 100 times a day. So the symptoms are different, but the concept is the same. Body dysmorphic disorder is a condition marked by excessive preoccupation with an imaginary or minor defect in a facial feature or localized part of the body. The diagnostic criteria specify that the condition must be sufficiently severe to cause a decline in the patient's social, occupational, or educational functioning. Body dysmorphic disorder can be differentiated from the distorted body image, which is a defining feature of eating disorders, in that distorted body image involves a preoccupation with overall body mass, whereas body dysmorphic disorder involves focusing on a specific part or feature. People with BDD will undergo unneeded cosmetic surgery, dental procedures, or dermatological procedures to correct the perceived flaw, but are typically not satisfied with the results, as this is an internal perceptual problem. Typical age of onset of body dysmorphic disorder is ages 12 to 13, with the average age onset of 16 to 17. The incidence of body dysmorphic disorder in the United States is 2.5% for men and 2.2% for women. Probably one of the most famous people who suffered from body dysmorphic disorder is Michael Jackson. On the right-hand side, you'll see at the top a picture of him back in the late 1970s when he produced the album Off the Wall. And there you see on the bottom a picture of him after his arrest for molestation charges circa mid-90s or so. And you can see that he has undergone significant facial reconstruction surgery to try and lighten his skin, change his nose, change the structure of his face, especially his chin, lips, and cheekbones. And, a lot of psychologists have speculated that it was because he looked so much like his father, who had been very physically abusive towards him, that he wanted to erase that image when he looked in the mirror. So the risk factors include sexual trauma, child abuse, bullying by peers, and a serotonin insufficiency or imbalance. So in other words, depression. Moving on to hoarding disorder, which is a psychiatric condition that produces symptoms such as the compulsive urge to acquire unusually large amounts of possessions and an inability to voluntarily get rid of those possessions even when they have no practical usefulness or monetary value. They experience feelings of anxiety or mental anguish whenever these possessions get thrown away. Most affected individuals accumulate things with limited or no real-world value, such as books, old magazines or newspapers, self-made notes, outdated clothing, or old mail. The collected items typically produces enough clutter to limit or prevent the practical use of that space. When that space is no longer functional, that's when the problem is at its worst. In some cases, the collected materials also produce an active, ongoing danger in the form of such things as fire hazards or hygiene hazards. And if you've ever watched the show Hoarders or Buried Alive, Hoarding, there's two different shows, they will definitely show you how horrible it can get with the amount of bugs and vermin that will show up because of the rotting food. And then you have situations where newspapers are piled up in front of doorways and people can't get out in case of a fire. The general current population estimate is approximately 2 to 6%. We don't always know until the person passes away or there's a criminal complaint made that the house is stinking up the neighborhood. Gender prevalence is unclear. Average age is 50, although age of onset is often prior to 20. Functional impairment and clutter get worse with age, and there is support for both genetic and environmental factors. The decision-making deficits include indecisiveness and churning, which is where they move things around without actually getting rid of anything. The picture on the right is a very famous case of in the 1920s. This very wealthy set of brothers in New York had filled their Fifth Avenue apartment with so much clutter and junk that what you see is their only means of moving around in their apartment. One brother who was blind died. He got trapped and fell and died, couldn't get out. The other brother eventually also died in the apartment. And so when the police broke in, this is what they found. And it was so bad that they just opened the window and started throwing stuff out. They couldn't even get through the apartment to find their bodies. Moving on to trichotillomania, which is known as the hair pulling disorder. It involves recurrent, irresistible urges to pull out hair from your scalp, eyebrows, or other areas of your body despite trying to stop. Hair pulling from the scalp often leaves patchy bald spots, which causes significant distress and can interfere with social or work functioning. People with trichotillomania may go to great lengths to disguise the hair loss. For some people, trichotillomania may be mild and generally manageable. For others, the compulsive urge to pull hair is overwhelming. Some people will pull hair from their eyebrows, their eyelashes, they'll go to town on their hair, but it is something that, when it gets out of hand, becomes very noticeable. Excoriation, which is about 1.4% of people who have this disorder, and is vast majority being women, usually begins in puberty because of acne. The face, arms, and hands are often the go-to areas for pickers, but the DSM-5 does also note that picking can occur anywhere on the body. The targets for skin pickers include healthy skin, minor imperfections, pimples, calluses, and old picking scabs, which can even be picked at with fingernails, which is the most common, or even tools like tweezers or pins. Picking can occur in short spurts throughout the day or for prolonged sessions. Some examine, play with, or mouth or swallow the skin. I know it's gross, but the vast majority of people, when they're chewing on their nails or around the cuticles, that's exactly what they're doing, and that's really the number one way of getting sick, because you're digesting everything that's fallen and gotten stuck under your nails. So, treatment for OCD is a combination of medication and psychotherapy. And as I mentioned before, cognitive behavioral therapy, or CBT, works really well in treating OCD. CBT teaches patients different types of thinking, behaving, and coping with situations that trigger obsessive thoughts and compulsive behaviors. The type of CBT that therapists have found most effective for treating OCD is called exposure and response prevention. The term exposure in ERP refers to the practice of facing the repetitive thoughts, images, and urges that cause the severe anxiety associated with OCD. So, for example, if you are very freaked out by the idea of germs and bacteria, anything that could be lurking, they might have you in a situation where you have to go to the bathroom and not wash your hands and then go eat a sandwich, or to scrub out the sink using your toothbrush, and then after rinsing your toothbrush, use it to brush your teeth. Now, yeah, that all sounds disgusting, but what you're doing is you're exposing the person to their worst fear and showing them that the worst is not going to happen. Because the vast majority of us, despite the overwhelming, requests by mom and dad to wash our hands after we go to the bathroom, have occasionally forgotten, and we've moved on with our day and not died. Or else you wouldn't be listening to this presentation. But, these things happen, and the reality is that we all survive. We have a certain amount of immunity built up that allows us to keep going. But somebody with OCD who has this issue is really going to struggle, and it's going to take them a long time. People who are afraid of flying, for example, will visit a therapist who might have a chair from an airplane in their office, and they will sit in that chair and walk through the process of takeoff, being in the air, and landing to expose them to their greatest fears. This goes along with antidepressants such as Zoloft, Paxil, and Prozac, and electroconvulsive therapy. And that's where they attach electrodes to your the front part of your brain, and they give you short shocks that will overwhelmingly help reset the electrical currents in your brain, and it has been shown to be very effective. All right, here's some of the works that I used in this presentation in addition to the textbook. If you have any questions, please feel free to text or email me. Otherwise, if you are not in my class, please feel free to leave me a comment and I will get back to you as quickly as I can. Thank you and have a fantastic day.